Welcome to the exchange, a series of rounds to drive change. This presentation is eligible for CPD credits. At the end of the presentation will be a slide where you can use your smartphone, connect to a QR code, and do the usual survey to get your CPD credits. My guest today is Dr. Julian Cernick. And first, Julian and I would like to acknowledge that we are on the traditional territories of the First Nations of the interior peoples, and on whose land we live, work, collaborate, play, and tonight we learn about Julian's lessons. I am on the Okanagan Nation, the Silk People's lands. Our agenda review is information and privacy and security. We just want to make sure that your privacy means a lot to us, and when we go to questions, we'll avoid using names, last names for individuals. Our Zoom tips include that this particular presentation, you use the chat box to talk to each other, and we have a Q&A section, and if you enter in your questions there, I will send them on to Julian, and we'll get into a discussion. Julian, I've known you for about 2 years now. You're an orthopedic surgeon in Vernon. I have a pleasure to be involved with you in the Navigate program as well. And I myself am Harsh Handel. I'm the Executive Medical Director for Physician Engagement and Resource Planning. And this idea grew out of the concept of grand rounds. So in terms of information privacy and security, these are being recorded and will be publicly shared. The presenter and facility names will be shared. Attendee names will not be published, although voices will be recorded during the question and answer portion. And as I mentioned, CME credits will be available at the end. Tonight's presentation is on crisis-inspired creativity and collaboration in healthcare redesign. And I turn this over to Julian to go through the learning objectives and carry on with the presentation.
Thank you very much, Harsh. It's a great pleasure to be here, and I hope we have an interesting discussion tonight. The learning objective is to have a discussion really about how a crisis can inspire creativity and unconventional collaboration, leading maybe to novel healthcare redesign. There are some Zoom tips there, but we've gone over those. We'll just carry on. In terms of the format tonight, I'm hoping that we can spend the next 15 minutes just describing what we experienced in our clinic and in our division in the first phase 1, let's say, of COVID-19 in BC. And then in the second 15 minutes, roughly, I'm going to discuss a little bit about how our experiences might be used to shape our future. And finally, I think, and probably the most interesting is going to be our Q&A afterwards, where we can hopefully really collaborate and learn together. So in terms of disclosures, firstly, I have a long-standing interest, and I'm a long-standing advocate of physician-led healthcare redesign. I really feel that physicians are an untapped resource in terms of their ability to contribute to healthcare design, and I think we have yet to really experience the full value of that. I do help in the clinic that I work at to try to redesign workflow in the clinic where I see patients. And I do expect to have a financial relationship with that clinic in the future, so just bear that in mind with some of the things we'll discuss tonight. But I think that's, many of us do have those relationships for sure. And in terms of why am I doing any of this, before I even became a staff physician or surgeon, even as a resident and a trainee, I recognized that the biggest stressors that I experienced were probably due to systematic problems which need systematic solutions, administrative headaches, which you can't solve at the patient's bedside necessarily. And so early on in my training and my career, I pointed myself in the direction of getting more training in that area and took the Souter physician leadership courses and other courses like that, like Harsh mentioned, Navigate and now PQI, and trying to just gear up to try to do the best I can at that part of my job, and have really imbibed that idea that we have two jobs. My job's an orthopedic surgeon, but my other job is to improve orthopedic surgery. And so just some disclosures there. I'm going to take us back to March of 2020. None of us really want to be dragged back there, but I think we're all having PTSD about this week in March because it's starting to happen again. This is March 16th to the 20th. This is my Google Calendar. I just kind of put this together as a reminiscence. So let's talk about what happened on March 16th. On Monday, we were told we had to do physical distancing, and working from home began, and meetings and sporting events of 50 people or over were canceled, and you couldn't go visit grandma in the nursing home anymore. And at that day, on Monday, we had 103 cases of COVID-19 in BC. Tuesday, how are we looking? Well, a public health emergency was just declared. The kids were all sent home from school, and the Prime Minister told people that were Canadian and that were abroad that they should probably come home because something was afoot. And we had 186 cases that day. On Wednesday, that turned into a provincial state of emergency. The US border was closed, and it became illegal to sell your toilet paper and sanitizer. You know, that was that whole fiasco. You couldn't sell food either, and to stop the people from keeping all their supplies to themselves. And on that day, we had 231 cases. The next day was Thursday, and we had our 4th death in BC from COVID-19 at 271 cases. And the following day, Friday, just to top the week off, we were told that personal businesses like tattoo parlors, barbershops had to shut down. And that day we had 424 cases. So in just 5 days, we had a 4 times rate, 4 times the number of cases just in British Columbia. And so then we went to the weekend. Great week, eh? Came back to work on Monday, March 23rd, and this is what we got. As health professionals, we were told that all non-essential and elective services were going to be canceled, and that we needed to keep those to minimal levels. We were told that we needed to make special room in our lives for emergent and urgent care. And we were told that we needed to figure out how to communicate with our patients via telephone and video, which in orthopedics had no precedent that I was aware of. We certainly didn't do any of that in our training. And in fact, it was probably regarded as pretty unprofessional behavior to largely manage your patients virtually in the pre-COVID-19 era. And we were also told that the health professionals were going to have to figure out exactly what those first 3 instructions meant. And they gave us some instructions, some pointers, but really it was up to us to decide. And so what happened? Well, lots of talking happened. And this talking was all over the show. It wasn't organized talking necessarily. There was official meetings for sure, division meetings and department meetings. There was RMACs and medical staff meetings, but there was also a lot of unofficial meetings and ad hoc corridor discussions, personal discussions with spouses and friends. And we just try to figure out, how are we actually going to do this? What are we supposed to do? And so some of these conversations generated really cool ideas, and people started to plan. And it was kind of a little bit like how maybe a code would have been run before we had ACLS or ATLS, sort of an informal meeting of minds and people just planning things on their own. This is our clinic, and this is what we did. We emptied it. We have a clinic with 19 beds, and it's about 9,000 square feet at the time. And we have a whole pile of physiotherapists and occupational therapists, and we sent them all home. We were told by the BC government that there was a $5 billion help package for these people, and that they were going to get supported, and we could safely let them go. So we did that, because that was what we were supposed to do, I think. And then we started having discussions about what are we going to do with this empty space. And someone at some point said, well, maybe the hospital needs it. We should look into that. And so we tried to do some forecasting. And officially, I was told in a briefing that we were to expect a doubling time of our COVID-19 cases of about 10 days. And so I was trying to figure out, as many of us were, how to predict what was going to happen. And so I did the numbers, and it was, well, terrifying. On March 23rd, we've got 400 cases, and by June 1st, we were projected to have 60,000 cases. And so I wasn't the only one doing these numbers. Everybody was doing them. And we've since realized, of course, that forecasting for COVID-19 is actually fairly challenging, and we're not that great at it. But back then, this is our first go around, and this is what we thought we were going to be dealing with, and it was pretty scary. So a bunch of us met up at the Orthopedic Clinic in the hospital. And we gathered together some administrators, and we started having a discussion about what would happen if we were to try to move the orthopedic clinic out of the hospital at Vernon Jubilee and down to the community into this empty space. And lo and behold, when we got there, there was a group of emergency doctors covertly meeting in our fracture clinic, having the exact same discussion, thinking about what are they going to do for extra overflow space, and eyeing our clinic, saying maybe we could get into this place in the hospital and get this clinic back to down to the community. So we all met, just an ad hoc meeting, and we started figuring out how we could do it. And we appointed a project manager, and we decided we were going to do it. And it was just like that. And, you know, kudos to the interior health leadership, because they told us overtly that we needed to have sort of disseminated disaster planning. They reflected on the Katrina New Orleans problem, and remembering who was successful in that disaster, and recognizing that it was people on the ground making leadership decisions on their own. It wasn't centralized leadership that was successful. Centralized leadership actually made a bit of a mess of things. So it's the people like the Walmart store just giving away stuff, just deciding to help people that was successful in Katrina. And so that's what we were told. You know, if you're on the ground, you make decisions that you think are right for your town, and we'll support you. And so kudos to them, because a lot of the stuff that happened came out of that direction. So this is our project relocation timeline. And just as you're looking at this, think about the last time you saw a project roll out in the health sphere. So on Monday, we identified the crisis on the 23rd. And then we decided to relocate the clinic while we had our discussion in the clinic up in the hospital. On Wednesday, a memo went out from our clinical operations director saying we were going to move the clinic. And then on Thursday, we saw patients in the clinic, just like that, boom. And so, you know, 4 days, and we're up and running from idea to rolled out. And so, and then that's just like light speed, really, in the healthcare community. What did we have to do to make that happen? Well, we had to get PPE training and PPE supply chain. That's obvious, and everyone was talking about that. But how many other things did we need to do? Well, we had to figure out how to get all the materials down there. So we literally just loaded up a truck, collected everything in the orthopedic clinic, and then in the afternoon, a bunch of nurses and orthotechs and administrators and surgeons literally picked the stuff off the truck and put it in the clinic in the new environment. We just did that in the afternoon. We had to have infection control come down and make sure that, since it's now an interior health site, we had to have infection control, make sure our janitors and everything were trained. We had to make sure we were up to code on violence prevention, and we had to make sure we had a fire hazard plan that interior health could live with. We even had medical physics come down. I didn't even know there was such a thing as medical physics, but they had to come down to make sure we could run a mini C-arm in our clinic. IMIT had to come to set up a VPN so that we could not only order entry x-rays, but also send our x-rays back to the PACS system on the computer. And then at some point we realized that we didn't have parking. So I called up our operations director and a director of operations, and I said, you know, how are you doing with the crisis? And to which he said, well, this isn't a crisis. You just think it is because you haven't been to war. So I knew I was talking to the right guy. I said, we need parking. Let's co-write a letter to the city of Vernon saying we need parking. And he said, oh, no, that's okay. How much parking do you need? So I told him, and 2 hours later, there were guys in reflective vests walking down the street, hooding meters and putting up interior health signs. It was just light speed. We had to have discussions with the emergency department to figure out how we're going to funnel patients. All the radiology clinics were basically turning away elective cases, so we needed to figure out how to pipeline our cases in there so they could get their x-rays in time for their fracture clinic. So all this stuff happened in 3.5 days, and then we opened. Just light speed. When you talk about team building, I mean, if you pay a group to do a vacation with your, say, team of bank managers and do some team building, they mock up a crisis, right? So you can get to know each other. And that's a great way to learn about your team. So what about a real crisis? How does that work for team building? Well, actually, I thought it worked pretty well, because during this process of this 4 days of moving the clinic, we had to figure out how to design the clinic, and we learned who is on the team. We learned, how do you contact them? I mean, my contact books filled up with people I didn't even know that department existed. And I figured out who in the department do you call? How do you get a hold of them? Is it email? Is it text? How quick are they at working? What are the skills of these team members? And then, you know, the soft stuff, like the Myers-Briggs stuff, you figure out, what kind of people am I working with here, and how do I have to talk to them? And so it was like a rapid fire team building exercise, you know, on steroids. So what did we actually do during this move? Well, from March 26th to May 6th, we ran the Orthopedic Clinic down in the community at this empty site. And for background, we usually in the Orthopedic Clinic will see about 60 or even 80 patients, sometimes 100 per day, 5 days a week. So we took that clinic, we moved it down into the community, but our numbers were way down because we were doing things very differently. So we saw 643 patients over the 6-week period. We did 1,000 virtual physiotherapy sessions. compared to pre-COVID, there was zero because it wasn't a thing. So we invented a whole new sphere of work. And then we invented this new thing, which we've been calling a collaborative consult, which where the surgeon actually does the examination with the physiotherapist and comes up with a treatment plan and a diagnosis, and then rolls it out with a physiotherapist following on while the surgeon goes to see the next patient. So that was a whole new thing that we learned to do. And you have to realize that orthopedic surgery didn't even have a billing code for a virtual visit. And then now we're doing these virtual collaborative consults. It was a whole new sphere of work and a lot of learning to be done. Tech learning and figuring out how to get our MOA to make sure the mute button was figured out for the granny that was going to call us. And actually it was really well received by our patients, I think, and a lot of grateful patients who are feeling a lot of social isolation and not knowing how they're going to get their healthcare needs looked after were managed in this new system. And I turned myself into a virtual surgeon overnight. I basically got to the point where I was seeing 20 new consults a day, 5 days a week, virtually, often with a physiotherapist. And so there's a lot of learning going on. So, you know, when you do a change project of this nature, sometimes people will just hold up kind of these two columns, the current state and the future state, just to compare and see like how different were things actually during this brief period in our history. And so let's just run through that a little bit. So in the current state, the way we usually did things, we would see every patient in person. And in the future state, we actually made a decision for each patient. Do we need to see this person appropriately in person? Do we need to see them virtually? Is it a telephone or a laptop type thing? Or do we not need to see them at all? So we weren't really making those judgments before this. We were to some extent, but for the vast majority of patients, we saw everyone in person in the clinic. In the old system, we would get all their imaging the day they arrive. So they come, get their x-ray, see the surgeon, see the orthotech, and go home. In the new system, we were starting to think about this. Well, do we really need the x-ray at this time? Could they get it in Revelstoke before they come down? Maybe they can get it in Revelstoke and then we just talk to them on the phone about it. Do we really need to examine them? And so we started to have this intelligent design and this appropriateness come in, you know, in a way that it really hadn't in the past. In the old system, we had our MOAs, individual surgeons' MOAs, booking clinics. In this new thing, we started to really actually focus on the institution to make sure we weren't having congestion. And so that changed the way we did things. And we started to level out volumes, making sure there wasn't too much congestion, and organizing x-rays and virtual visits before the visit. So really uncoupling the x-ray step from the orthopedic surgeon step to decrease congestion, kind of a new thing that we worked on. In the old system, we'd see all the patients on a schedule. You know, if you're a hip replacement, I see you at 2 weeks, 6 weeks, 3 months, 6 months, a year, and then every year after that. I mean, I've been saying that my whole career. In the new system, we're like, do we really need to see these people? Do we really need to expose them to a new x-ray? Are we going to change our management? So really just unpicking the system that we have inherited from our forebears with this new external driver to say what's appropriate. Do we really need to do it the way we always did it? And so lots of learnings, some positive, some negative. In the old way with physiotherapy, we would just write a prescription, you know, physiotherapy, and write something there. You know, was it legible? You know, where did it go? Sometimes the patient lost it in their car. Maybe they were too afraid to go to physio because it hurt. Maybe they didn't have the means to pay for physio. All kinds of barriers. So we make a lot of assumptions that our physiotherapy prescriptions actually went, you know, and were carried out the way we thought they might be. And finally, we realized that in the old system, the patient would pay for physio, or unless they were WorkSafe or ICBC. In the new system, we realized that physiotherapy actually is self-sustaining to some degree, meaning that if you assign a physiotherapist to our clinic, and we used volunteer physios that were laid off, if you assign a physio to that fracture clinic, because the workflow is so high, there's enough WorkSafe patients and ICB and insured patients in there that with just running the numbers roughly, they seem to be able to pay for a full day's of work, seeing all these people for free. You know, the ones that were not insured actually got care on the backs of the ones that were insured in terms of just timing. You know, we're not doing 1 hour physiotherapy consults, we're just giving them some physio contact. And because of that new workflow, we actually found that physio is actually fairly easy to fund without going to the foundation or asking anyone to reach into their jeans to pay for it. So kind of new learnings that we wouldn't have gotten any other way. So just going to talk a little bit more about physio, because I think it's a really big part of this. I think all orthopedic surgeons recognize that physiotherapy is a really important factor. But who gets physiotherapy is really quite inequitous. You know, the people that are from at-risk populations don't really get access to that in our system for trauma patients. the barriers to actually getting good rehab, really you need your patient to be engaged in their rehab. And so if you think a little bit about what might be the barriers to physician or patient engagement in rehab, there's confusion, there's communication. You send the patient a prescription. I kind of make the analogy that when you write a physio prescription, it's like doing a space probe. You just send it off into space. It's a one-way message. You don't usually get any information back. You don't know what happened with your message. And even if someone does get back to you about physiotherapy, you might be too busy to notice you're being communicated to. So that old system, this is a new system. You're working with the physio. You're right next to them. You take away some of those financial barriers. You take away the patient's administrative function to actually organize physio. And you really inspire more belief in the care because it's being administered by the physio. In the 70s, they did all this pain literature type stuff where they try to figure out what are the determinants of how well a pain medication works. And a lot of it has to do with what they call context effect. What are the spiritual beliefs, the beliefs of the patient, and how do you leverage those in order to get a better pain response? So we found out that doctor in a white coat giving an injection is better than nurse giving a pill. We even figured out what kind of pill works better for pain medications. Turns out the colored granules one is the best one. So there's all these context effects for pain. And if you apply that to physiotherapy, a lot of times physiotherapy, the barrier is pain, and you're trying to get range of motion or strengthening. And so, if the physician is there making the diagnosis, clearing up communication issues, and really instilling faith in this system that this is what you need and this is what's going to work, that really goes a long way towards helping with physiotherapy. So I think your outcomes are actually better. And it's cross-training. I mean, you're working in a team. It's actually just nice to know what the physio knows. They get to know what you know. And pretty soon after working together for a while, you develop a real team approach. It's safer, it's easier, it's nicer, it's better for the patient, I think. And then, of course, you can use them as an extender because they can go see the patient on a schedule without you seeing them, and they've been there from the beginning. So the physiotherapist can trigger you to say, look, this person's not doing as well as we thought they would. Maybe you need to see them again. So it's actually safer, and it helps to bridge that gap of this new virtual care mode that we didn't have before. So the old system, this is the healthcare team in the fracture clinic. There's your orthopedic surgeon talks to the orthopedic technologist. There isn't anyone else in the room, right? Well, there sort of is. They're at a distance. Members that are outside the team, we're dimly aware that there's the x-ray tech somewhere in the building that's doing something. The radiologist is doing something somewhere. And of course, the patient's part of the team, but we sort of almost systematically disrespect their time. I mean, we expect that they're going to wait for hours sometimes in fracture clinic because there's emergencies and it's unpredictable, and we've just kind of gotten used to that. But I don't think they ever get used to that as patients, for sure. Our system is really one that has evolved so that each node in the system, the orthopedic surgeon, the radiologist, the radiographer, these people have all evolved their part of the system to make it best from their lens. But if you look at the patient's journey, kind of what they call a process map, where you walk along and you follow the patient through the system, you actually find it's fairly chaotic and inefficient for them. And so we don't have a system that's been intelligently designed. We've got one that's evolved, and I think that's a bit of a gap. If you look through our actual team, when we put this clinic together, well, there's our team. I mean, it's more than just the surgeon and the orthotech. Look at the number of people you've got involved and the different things that needed to come together. So if you drew a process map for this team working on the patient, it's actually pretty chaotic. In terms of system design, let's get into a little bit of stuff that I've learned in some of my courses. Now, bit of a disclaimer, I'm by no means an expert on system design. I'm not putting myself out as one. I've taken courses from people that are, though. And so there's this thing called TRIZ. TRIZ stands for something in Russian. I think the shorthand is in English is the theory of inventive problem solving. And what I read online in preparing for this talk is way more than I actually knew before I prepared for this talk. But in simple terms, it was described to me as a system by a Russian engineer called Altshuler, where if you're trying to design a system to work well at a particular task, what you can do as a psychological test is think about all the things that you would design into that system to make it for sure fail as badly as possible. And then do the opposite in your system design. So if you're trying to think about, say, communication in a fracture clinic, what are the things you might build into it to make it really poor? Or if you're trying to think about compliance with physio, how would you set up your system to make it really unlikely that you're going to get high quality physio for patients? So I don't have to probably even say some of those things because they're kind of obvious, and a lot of them are actually the way we do things. So I just put that out there, the difference between an evolved system and then one you overtly design. There might be shocking differences in how you would design it if you started from the ground up. So where are we now? Well, the COVID crisis seemed to have taken a back burner where elective cases went back to the hospital. And with that, the fracture clinic went back to the hospital on May 6th. And we started out with low volumes and doing some virtual care, but I'll admit we've regressed back to where we were before. Our volumes are climbing up there again. We're seeing a lot of people in person. We're doing a lot of our imaging in person on the day of the crisis, the day of the visit, I should say. And we're getting congestion in our hospitals. And we're starting to worry, maybe this isn't the right way. And so is there something we can learn from this episode in our lives where we did things quite differently for 6 weeks? And so I'll put it out to you. And this is for us all to think about, because we all did things differently in that first little blip of COVID. Do we have the skills to utilize the lessons learned in a crisis once that crisis is passed? And what are the barriers to rolling out a crisis-inspired program in your site? And how do you manage the culture problems on the road to acting on this new strategy that you might have? So you can get pretty confident when you have that system when the crisis is on and you do the Walmart thing and you give away all your stuff, but that's not appropriate in peacetime. That was a wartime thing. You can't just open the stadium and have people that are hungry come and sleep in the stadium in Katrina. That's a wartime thing. So how do you move from that, which was accolades for doing things that people did that on the ground, to how do you roll that out in peacetime? And I took an avalanche course on the weekend, and the instructor said this. He said, confidence is the feeling you get right before you fully appreciate the situation you're in. And so that's where we were on May 6th, I think. We were like, wow, we totally fixed like so much stuff. We're awesome. We're going to do everything just like that. And then, reality comes. You start to say, wow, okay, this is actually quite different from doing it when there's not a full-blown scary crisis going on. Even though now you could probably make the argument that we're actually more hazard than we were on March 23rd. In any case, I think some of the principles here are that, when you're trying to engage your physician colleagues and those around you, you can look at charts like this. This is coming from the International Association for Public Participation, not physician participation, but I think the lessons hold here. There's a spectrum of involvement from informing somebody, there's a COVID crisis, we're just going to let you know what's happening, all the way through to empower, there's a COVID crisis, you take care of it and then let us know what you did. And along that spectrum, there's consultation where you just maybe give your opinion, all the way through to collaboration, where it's a real team environment. And you've got to be very careful with your colleagues and with each other that we don't say we're empowering you, telling you to fix the system, when we're actually just going to inform you and do it ourselves. So you can get people on the wrong side if there's this perception that they weren't genuinely collaborating or involved. And so that's just something for us all to be aware of. And my final comment before we get into a discussion is that there is this thing called positive deviance. And positive deviance has a number of different definitions, but one of them is it's the ability for communities to discover the wisdom that they already have and then act on it. And said in a different way, something that might have worked in Valley A might not work in Valley B. And so be very cautious about taking lessons learned in Toyota and seeing if you can make them work at Chevy, because sometimes you learn that culture does eat strategy for breakfast. And that's one of my favorite quotes. And I think, you can have great ideas, but the way in which you roll them out is probably the magic or the secret sauce. So, in Valley A, they come up with a solution and they got all the physicians engaged. It's probably the process of physician engagement and designing their plan that's the secret sauce that made it work, rather than the 2-page letter they wrote at the end of that, which you just can't take that to Valley B and expect any of those physicians to do it. They're probably going to need to recreate some of that engagement process so that they really own the new thing and so that they can genuinely put in their knowledge of what Valley B is all about. So with that in mind, I think this is probably a good time to just stop and have a question and answer period. I've left this slide up, which is kind of what I think the major questions in my mind are, and very curious to hear feedback and have a question and answer period.
So feel free to enter in your questions into the Q&A section at the bottom of the Zoom screen, or put in your comments in the chat. Julian, I think after that first period, there was a real fear that we would go back to the way that we did things before, right? How do you make the case that what you did before, during the crisis period, how do you change your approach to moving through the system?
Well, I think, if you look at that positive deviance concept, you could think for a second that the dynamics in the crisis are actually significantly different than the dynamics in peacetime. And so what you maybe shouldn't do is make the assumption that you're just going to do everything you did in the crisis over again. And I think that's actually where I started, which is weird because I've taken a bit of training in this area and you'd think I would not do that pitfall. But I think that's kind of where my head was at. And then I realized, look, maybe we treat the crisis as Valley A and the peacetime as Valley B. And so you've got these ideas, you've got a whole bunch of great stuff that happened. People were exposed to new stuff. But don't make the assumption that that's going to happen in peacetime. Maybe go back and say, okay, let's build some culture, let's build some communication, some networks, and some teamwork, and let's all discuss what can we do going forward, inspired by the crisis as a team of all the people that are those stakeholders in that big team I mentioned, right down to parking in the city. Maybe that's the organic way to do it, so that you're not coming with a ready-made solution, which people say, look, the crisis is over. I just want to go back to how it was before. This is all very stressful. I don't want that. So I think maybe that's the lesson learned.
And what was the working with the physiotherapist so closely? You mentioned how it changed that sort of collaborative approach that you hadn't experienced before in your training. Are you still able to continue with that collaborative approach? And what is the feedback from the physiotherapists that you work with?
So the physiotherapists, they're people that work in my clinic. So they're my partners in a very genuine sense of the word. And so they love it. I was just the other day in my office and one of the physios came up to me and said, hey, how come you're not inviting me to any of these collaborative consults? You used to invite me all the time. And I said, look, I think I'm actually doing less of them, because I'm kind of regressing to how I did things before. But, and I am seeing people collaboratively with other physios, so I'll include you. I mean, they really love it. The feedback from the physios is they love it. I think if I were to summarize what most of the physios that I've worked with really want, is they want to be genuinely included in the healthcare team, not peripheral. They don't want to be the space probe where they get a one-way message and they're not really involved. They want to learn just like we do. They want to be involved and they want to understand what they're doing, and they can become far more productive if they're exposed to our clinical environments personally, not on the outside. And so I think you actually make the most of your human resource. They're a resource. You make the most of them by involving them, and you actually make the most of yourself by learning from them too.
There's a question from Glenn that asks, how do we keep the skills current for pandemic training? What do we need the rules or the principles of engagement during a pandemic? I mean, you guys got together, went over to the clinic, found a bunch of emergency physicians sitting around dealing with the same issue. There's general advice is how do we refresh those rules as we go along? Because we've had in interior health, we've stood up 2 EOCs, emergency operations centers, secondary to wildfire, flooding, and now COVID per year over the last decade. So it's not like a rare occurrence, but it seems each time we have to rediscover the rules. So any general advice in terms of having some rules in place?
I think it's a really challenging area. I think every crisis is quite different. And I think that's probably why, there's kind of a rewriting every time. I think probably what we're currently doing in interior health is probably the thing, like to expose a larger group of physicians to leadership courses and training, to start to work across different sites with physician leaders so that they actually know each other. I mean, the people that we're in these courses with, I reach out to those people all the time. I'm like, hey, I got this weird thing going on. I don't know what to do with it. What would you suggest? So you develop these networks of people. And I think that's what we're doing in interior health is building basically a generation of physician leaders that are mentors to each other and have official mentorship and some training too. And so you develop these unofficial networks that people you can reach out to. So when this does happen, maybe you're not doing team building for the first time, and if you are, maybe you've had a chance to drill this a little bit, just like practicing for a code. And so I think that's probably what helped us get where we were this time. And I'm working on other projects, which I'm using the same team members for. I'm reaching out to the head of radiography, in Vernon Jubilee, who I met basically through this crisis and worked with. And I was like, well, we get along. We can do some really good stuff together. And so now that's my new team player. And if we have another crisis where I need to collaborate with other divisions, those networks are set up and ready to go.
And what about our administrative partners, your relationships with them?
Yeah, I mean, absolutely. I didn't. I moved here 18 months ago, and I moved from a situation where I was the RMAC chair in a different region, and so I knew all the administrators really well. And then I moved here, and I didn't have a role anymore, so I really didn't know those people at all. And so this team building exercise gave me contact with those people, and also built credibility on both sides of that conversation. So we all know each other. They know me. I know them, and so yeah, those communication paths are wide open, and we're having conversations, and it's really highly functional now, as a result, partly of this team building exercise of a real crisis. So yeah, there's a real improvement, at least through my lens, in communication.
One of the questions was in terms of the physiotherapist compensation. In terms of this collaborative model, it's not covered under MSP, right?
Nope.
So, are there structures that help that? You mentioned having a collaborative model using funding to ICBC and private insurance to offset public physiotherapy. What other thoughts have you come up with?
So we did think about this, and one of the things that has happened, which isn't in my talk, is that as one of my projects, I worked on a business case of actually doing this in our clinic on a sustainable level. And so some of these things you can do in a crisis, you probably might not be able to do them in a sustainable long-term model. So we worked with contracts and with the administration leadership, both the senior leadership and local leadership in Vernon, and we put together a financial Excel sheet, basically saying what are the current costs, what were the future costs, and how would we fund physio for these patients if we were to do this off-site. And some of the things that can be done is really, it's an efficiency situation. I mean, if you can create a very efficient system using, sort of applying, private sector business skills and looking at this as an efficiency model, I suspect there's enough savings in there that you can use the same hospital budget, see just the same number of people, and produce money without asking for handouts for physiotherapy. And the kinds of things you do is, you instead of, say, having each MOA spend hours fielding phone calls, you have a central booking clerk. And the central booking clerk does things like smoothing all the wait lists on each day so that you're not having these peaks and troughs, which are very expensive and hard to staff. So if you do some intelligent organization of the system by paying a booking clerk who's much cheaper than an RN, then you can probably save on RN fees. You can look at these people and say, these people don't have to come down. We're gonna actually screen them with a clerk who's got some algorithms and make it so that these people are seen virtually, which is a lot cheaper. And we're going to skip on imaging we don't need to do. I mean, there's vast savings to be had in applying these lessons we've learned. And so I'm confident that we could easily pay for physio just by efficiency changes and just taking a different lens. Some of those lessons I pointed out.
So Graham, as you know, is really into disaster management, emergency planning, and his suggestion is that we really should be engaged in more tabletop exercises, and perhaps that can actually be applied to our processes in the sort of TRIZ format to see what really works. What's your thoughts on the more tabletops, and what's your thought of involving patients in those tabletop exercises?
Yeah, I know. I mean, I think I'm just going to answer that last bit first because that's such a strong point. I mean, I think involving patients is mandatory. It is so easy to get off track. I mean, a bunch of orthopedic surgeons talking together, they're just all getting higher on their own fumes. You really need a patient there because then that person can say, well, do you know, like I was in the fracture clinic and it was a 4-hour adventure and I had to ping pong around here and there and I was standing cheek by jowl with coughing people and I didn't want to be there. Can we do it another way? Whereas, when we see it from our own lens, it's very easy to kind of just get used to how the patient's experience is. Not saying we're callous or not thinking. It's just you easily get distracted by the wallpaper in your office and what your pressures are. And so I think having a patient voice at those tabletops would be really, really good. And I think drilling is important. I mean, we don't have to. We can learn from other environments, right? Hospitals that do mass casualty incident preparing, they're better at mass casualty incidents. Hospitals that do have a trauma team and do trauma team education with their team every year and ATLS certification with their team, homegrown in-house education, they perform better in trauma. I mean, why are we reinventing this stuff? We know that that's going to do better. So yeah, for sure, we should have we should do that stuff for sure.
So at this point, you've gone from in hospital, right, out in the community. You're back in hospital, and now it's a question of managing the culture change to see, is it feasible to go out of hospital again? Or is there a mix? Is there an in-between solution? What goes out of hospital and what stays in hospital? How do you have those conversations, Julian?
I think with great caution, I think, for sure, because yeah, I think what a lot of people probably will agree with is that physicians want their autonomy maybe above every other metric. And so even though we are the division of orthopedics or you're the division of family practice or whatever group you're in, really you do want to do things the way you want to do things. And we always respect that in each other. And so there's this maybe we haven't developed yet a culture where we can do that. Maybe we're not at that stage yet in terms of trust building and having a track record of innovation. I mean, you know, there's that whole sphere of thought that says you've got to be able to fail forward. I'm not an expert in this stuff, but I've heard talks on people saying things like, you know, failing forward, and, you know, high functioning companies fail a lot, and that's how they get innovation, because it's a safe place to fail. They can try stuff and move forward. Like if you think about your own group, whatever physician group it is, how good is your culture at tolerating failing? Like, can you fail forward? Is that a thing that you do in your group? I mean, we're talking about innovation here. And so I think you've got to take an innovative lens and say, like, as a corporation or as a group, do you have the necessary culture in place and the relationships to fail into innovation and to do that? And so I think that's where my thoughts are. Is I think I've learned, and a little bit that just the tip of the iceberg probably, that there's a ways to go if we're going to create a situation where we can just leap from a crisis innovation to doing it. I think we've got a ways to go, and I think it's slow steps, and I think it's culture, and it's you know, just basically going through your life saying, I'm just going to incrementally push the trust in the right direction, and it might take years and it might take months, I don't know, but hopefully we can get a few wins, and then we can generate some credibility and some trust. And those things are at odds, because getting a win is not failing forward. You have to fail to innovate, and so it's very challenging. You got to be delicate, and I think it's slow work for sure.
Thanks, Julian. I have Graham who has a question for you, a comment.
Hey, Julian. I hope you can hear me.
Yeah, I can. Perfect.
Fantastic talk. A great topic, and I think you've really picked on some key points of this. So you asked the question, do we have the skills? And I think COVID showed us that we could be innovative and adaptive. And so I think we have skills. My question is that often following a crisis, there's a period of, whether it's exhaustion or apathy, where we return, the adrenaline's disappeared, and we return back to our pre-event state, as you mentioned. So how, in your experience and your reflection, how do we maintain that positive change? How do we avoid that sort of exhaustive apathy, or just, you know, go back to what you did normally?
You know, I think it's human nature to adjust quicker than we think, you know, and so when the stress is off, or even when the stress is on, we just auto-regulate back to this is the new norm, and we've all just become used to this. And so I think to some extent even if we're still in the crisis, like actually by the numbers, we're more in a crisis now than we were on March 23rd by far. But
Absolutely.
Where's our cortisol level as a society? I mean, we've just homo-regulated, and now this is the new thing. And is it still a crisis? Do we call it a crisis now because we're used to it? So I think that's part of it. It's not possible, I don't think, to stay in crisis mode, and I'm not even sure if it's healthy or wise to. I think when you're in that mode, there is a tremendous explosion of innovation that can happen, because the risk from outside is so high that you can take risks inside. you know, because there's an external threat. So you can afford to take risks to control that. And in fact, if anything, that might even give you a sense of control over the crisis because you've done something. But as you become used to that crisis, I don't think it's natural or normal to stay in that state. And I think you've got to switch gears and say, okay, so that here's a list of ideas. Let's publicize them. Let's talk about them. Let's meet overtly on the, what did we learn? And maybe that's what we should have done in our group. Maybe we should have sat down and said, okay, we're moving back. It's time for an actual meeting. And let's talk about our experiences and write them down and talk about them overtly and think, okay, is this going to direct us, or are we going to do some of this in the future, or none of it in the future, or all of it in the future? So I think probably actually recognizing the value of the crisis and having specific time carved out to mine the value of the crisis, because you're going to exit it. Even if the crisis is still there, you're going to homo-regulate to it. The urgency is going to be gone, and that's going to suck the wind out of you to do anything about it. And very quickly, you just, even I kind of forgot how we did it. Like, yeah. It's just a past. It's gone now. So you got to do that right as we should have done that. Probably, you know, May 6th, we probably should have had a get together, the whole crew, that whole team I showed up there, everyone. We should have probably just got together. Let's do that next time. Next time the crisis has gone away, let's not forget to meet and mind the crisis. That's what I would say.
Yeah, I think you just picked on that too, is that we often just kind of stop rather than sort of spending a little bit extra time in breaking that down, seeing what we learned. Because that true resilience is not just building back, it's building back better. So thanks so much.
Great.
Not all crises are created equal, Julian. You are in the midst of the greatest crisis in world history, and we're entering a second wave. What opportunities does that create for you?
Well, that's a big question. Well, I don't know. The true answer is I don't know. But I think having talks like this helps me to develop a bit more of an overt approach to these things. And I hope publicizing it, like in the way that we're doing now, where we're actually talking about it, I hope that sort of gives us, primes us for the next move. I think the one thing that this has sort of ignited in me is a desire to be part of those innovative things and to be part of the leadership that is involved, because I really see that as an opportunity to have a big effect. And it more so than the effect at the bedside. So it's kind of like teaching in a way. You know, if you teach, you influence a generation of students. If you lead, you have an effect, a greater effect, a leveraged effect. So I think, I don't know what opportunities it's going to offer, but I'm just going to keep working with the networks we've discovered and see where we can push this to, and see how we can use this crisis to innovate. So I'm always interested in opportunities to learn and to lead where it's appropriate.
And Julian, your experience is creating solutions at the local level, innovation at the local level. Do you see ways, you know, the big question always keeps coming up in quality improvement science is the idea of how do you spread ideas? How do you take local level ideas, knowing that our history isn't very good at this, right? The surgical checklist, as you remember, was quite a failure in Ontario and attempted province-wide spread. Do you have any thoughts about how we can evolve that? How can we take these local ideas and encourage spread as opposed to force spread?
Yeah, and I think it all comes back with physicians and healthcare teams in general. Honestly, I really have come to believe it all comes down to physician engagement. And, you know, some people see physician engagement like this. There's a Venn diagram and there's no overlap. You know, you don't want that in your team. And if you, at all sense that you have that, you really need to think about the engagement first before you start doing spread. So, you know, we have this great radiology project right now where we're standardizing MSK imaging in interior health. And I had a conference call with some leaders in Northern Health who had heard about this, and they said, hey, we want to do this. Let's have a meeting with our orthopedic surgeons and radiologists, and we'll do this here too. And so one of the very well-meaning senior orthopedic surgeons said to me on the phone, I don't even know why we're having this discussion. Why don't you just email your order set and we'll just do it here? It's obviously the best thing. And we'll just do it in Northern Health and we'll just tell everybody these are the orders. And you know, so that was, you know, I think basically forgetting about the physician engagement step in somebody that maybe hasn't tried to roll out a big program before. And so what I said to him, and I think this is the key, at least one of them is as far as I can see, is that the secret sauce in our radiology project is that we had this grassroots team that we built up from orthopedic surgeons and radiologists and radiographers and nurse, unit managers and administrators, and we built this process collaboratively. And so we've got a lot of support because people have really been involved and collaborated. They weren't just consulted, they weren't just informed. And if you go to a physician group or a healthcare group and you just inform them, we're going to do this, it's going to fall flat. Doesn't matter how good the idea is, it's going to fall flat. So the thing to copy is the process by which they got the 2-page order form, not the 2-page order form. The money is not the 2-page order form. It's very easy to go, what a successful thing. We all just do this now. That just doesn't work like that in healthcare teams. So you got to copy the process, not the outcome.
And it really is about engagement and building those relationships. And that's the foundation of innovation and change. Thank you, Julian. And we'll just wrap things up. And I really want to thank you for taking the time. A brilliant presentation tonight. Thank you, everyone. Take care of yourselves. Be safe. Have conversations. And think about what we can learn to make care better. And thank you, Julian.
Thank you.
Good night.